My name is Dr. Edward Ngwenya, and we continue with our plastic surgery podcasts. Today's topic will be addressing the topic of distraction osteogenesis. Distraction osteogenesis. What is distraction osteogenesis? And I think it's a topic worth covering because there are some technical elements that I think most miss, but need to be just clarified. So this will be a succinct overview. I'm just giving the basics. Remember, there's always detail, and as I always say, these podcasts do not aim to replace your learning, but to augment your learning. Let's go on with it now. Distraction osteogenesis. So what is distraction osteogenesis? We know osteogenesis is the process of bone production, if you may. And the distraction osteogenesis, what it attempts is just to aid or to assist the bone healing. And this is done by application of a mechanical force. So I would define it or sum it up as aided bone healing by application of a mechanical force. Now, this is something that did not start now. I know the name that comes most often is Elizarov. But this did not start with Elizarov. In fact, there's a certain surgeon by the name of Bernard van Langenberg. Bernard van Langenberg, if you go deep and start reading in 1860s, I think 1869, he came in with this technique where he attempted and described it. In fact, he worked quite a lot, known a lot regarding, the military and warfare, where he was a surgeon therein. By the way, just of note, this is a very same surgeon who had people like Bill Roth, the operations that we do, surgeons, Bill Roth 1, Bill Roth 2, gastrotracheostomies, all of those. He was actually a trainee of Bernard van Langenberg. Other people like Kocha, of which we use the Kocha retractor, he also was trained by Bernard. And actually, of interest, I know I'm diverting, Bernard was actually and is lauded as one who started the residency program, actually introduced the residency program. And if you look and you go deeper into history, you'll find that. But let's not go away. So he then described it, but we also see it in, throughout in the works of another surgeon, Alessandro Codivilla. Alessandro Codivilla in 1905 described, or rather wrote about 26 patients where he actually did an osteotomy on the femur and he distracted the calcaneus. A lot of complications you can imagine that happened, but already the idea, we start to see it generating from the early 90s. So when Elizarov then comes in a bit later, he's building on the works of others and actually then looking at all the complications and actually then coming and proposing something which then works. So generally, it's very rare that you do something on your own, a lesson that you can learn. But in science, we build on the works of others, and certainly we sit on the shoulders of giants as dwarfs, so we can see further than they saw. Then there was Elizarov, as I've explained. He came in, Gavril is in the 1950s. That's about 80 years later, where he then introduced the external distraction device. And we'll see when we speak about other areas, there's another gentleman known as Wolfgang Rosenthal, actually a procedure that was described by him been cleft or posterior pharyngeal wall reconstruction in patients with VPI. The Sean Born Rosenthal, this is the same surgeon, and he spoke about distraction osteogenesis, particularly in the mandible in the 1930s. So that's way before Elizarov comes in now. Gavril Elizarov in 1950 then introduces this aided bone healing by application of an external fixator or an external distractor, which gives this mechanical force. So let's get into this bone, this distractive osteogenesis. So there are stages to all of this. Now, Elizarov then came in and described these stages, known as the Elizarov protocol of osteogenesis, and he divided them into three. He said there's latency, and then there's the activation phase, and then there's the consolidation phase. Latency phase, about 1 to 7 days. Activation, which will happen for a defined period up until you've reached the length that you aim for. And then consolidation will generally be about twice the time or the duration of the activation phase. So we're going to break it up as we describe this to go into each particular phase. And I would like you to understand this as a continuous process. And I hope through this explanation, you'll be able to understand why we actually do osteogenesis. So we remember the normal bone healing, as we should know. Normal bone healing, remember there's primary and the secondary. So if your bone gets injured or you've got a straight non-complicated fracture with no gap in between, you will have primary healing in that you won't have a hematoma that then forms, a secondary callus that then forms, but you can heal primarily. I'm not going to go into details regarding that, but it is covered in one of our podcasts on bone grafts and bone healing. So now I assume you know those basics. So we then have secondary bone healing, of which you are aware of, where there are, let's call them 4 phases. The first, as you break the bone, the cellular process that then happens, the first will be a hematoma that then forms. After you have a hematoma, we go into inflammation. After inflammation, we go into proliferation. And then the last step becomes remodeling, when now, we have aligned and our Havasian systems on the cortical aspects, they align, and we now have this remodeling happening. So when we look at these phases, all that they do is they are a representation of the bone healing phase. So what then happens in latency? Let's group it. So in latency, we actually cause a fracture. So we want bone healing to happen by inducing fracture to a specific site. Elizarov described the protocol for lengthening long bones of the lower limb. So, and of course, just to let you know that there are other protocols that exist, especially craniofacial skeleton, but we're going to describe the Elizarov protocol. So what we do, here we have a long bone, call it a tibia or femur, and we then do or perform an osteotomy. Now, there are different types of osteotomies. There can be a complete osteotomy or a partial osteotomy. Complete osteotomy, as you can imagine that bone, you cut it fully and there's a gap, evident gap in between. But then there's a partial osteotomy where you can have just, the periosteum as described by Elizarov, and the marrow that is preserved. So you can have periosteal and marrow preservation, bone marrow preservation. So those are partial osteotomies that you do, where it's just a corticotomy, just the cortex, however you leave then the medulla intact. So an osteotomy is performed, by the way, may I make a note there in that an osteotomy is not always recovered or required, as you will see when we now speak about, the craniofacial, where the technique is now used for in the cranial sutures that can serve as, call it an osteotomy or caelus. So we then perform an osteotomy. That's the first thing that happens. And then we apply a distractor. Now, there can be different types of distractors, and generally you must just know that it can either be external or internal. It can also be manual or automated. But generally, we group it as external, where you have the distractor that is outside, that is put almost like an X-fix, and then it would have pins that go in, and this long circular anchorage component that is around there. And then you would have screws that you then screw, the axial screws that will then increase. And therein, I've actually described to you the components of a distractor. And the components of a distractor are: 1, pins, which are the interosseous component; 2, the anchorage component, which are those bars that pull; and number 3, axial screws. And they are the ones that actually generate the distractions, the ones that you would generally adjust. So the types of a distractor we've explained, and they will work. There are those that are internal, where we put in a bar internally, and then we would then using that then distract either automated or externally. So you may think of it almost as call it like a femur and intermedullary nail that may be there, and then with pins on both sides, and that will then split and actually push rather than pull rather than the push that may be used with the external devices. So let's go into the phases, which is what I'm trying to get to. Now, we said you perform the osteotomy, and so what's the first thing that's going to happen? You're going to have a hematoma. Now, after you have a hematoma, you see, the process immediately after the osteotomy and the application of a distractor is this latency period. So it involves a hematoma forming, because you're going to have a gap there of at least 1 millimeters where hematoma is going to form. And then you've got inflammation that will form. Remember, I'm not going to get into the granular details. You should know what's there in inflammation. But then this, I can say, is driven by 3 physical factors. Number 1, a decrease in oxygen tension, a decrease in the pH, and the electronegativity that you will then cause within that. As you know, externally it's a positively charged, but internally here now in the middle we've got this negative electronegativity that now stimulates this inflammatory phase. And this generally takes about 1 to 7 days. Anything between 5 days to 7 days would be the latency period. Now, remember then what follows after inflammation. Now, this is happening. Remember, we've broken the bone, we've done the osteotomy, we've applied the device, and we let the physiological process then take place, which is the hematoma, which is inflammation, and the next stage, which is proliferation around day 5. Now, this is now the key, the part that I want you to understand. With proliferation, the normal proliferative phase, wherein we form now our caelus, from a soft caelus, from the chondroblast to the hard caelus, from our osteocytes will then come in. The difference is that During this period, we have increased granulation tissue and mesenchymal cells and capillaries. However, they are in a random orientation. So the orientation is random. Now, this is the ideal period for distraction. Because remember what I said, distraction is aided bone healing. So bone healing is happening, but as proliferative phase comes in around day 5 to day 7, we then initiate our distraction. That's when we now start to distract. So the distraction device is now activated there. Why? Because this healing is done in a random orientation of this granulation tissue, and so we want to align it so that it does not happen randomly like that. So when we then apply the distractor, what then happens, and we activate it, we then start to form a different pattern of healing. Histologically, when we look at the site, it's described by the 5 zones of healing, which would be, the zones that include the transitional areas, which are in the distraction gap. What are those? So if we look at it microscopically, we then start to see that, there's a central zone. There, in that central zone, is an area of mesenchymal proliferation. Then there's another zone, which is the paracentral zone. This is the transitional zone, the zone of apoptosis. And then right next to the bone, there's the distal zone, which is the area where remodeling occurs, the remodeling zones. So those are the 3 zones. However, in between these zones, there's transition zones, 2 transition zones specifically. So there's the central zone, which we've mentioned, where there's mesenchymal proliferation. And then next to this central zone, there's what? There's now an area of vasculogenesis. This would be between the central and the paracentral zones. This is now the vasculogenesis that happens. And then between the paracentral and the distal zone, we then have mineralization occurring. That's the other transitional zone that are there. One, vasculogenesis between central and paracentral, and then the other, mineralization. So then we target this, but remember, we can't just distract at 10 centimeters at a go. No. We would then distract at 1 millimeters per day. Now, I'm going to, in that, by the way, there are different strategies to do that. You can either break it down and say you are going to do it BD. In other words, you are going to do them in increments of 0.5 and another 0.5, making 1 millimeters. Or you are going to say, no, there's others who say we do it in 4 increment zones. So within the 24 hours, we distract 1 millimeters in 4 divided areas, meaning 0.25 millimeters times 4. So 0.25 millimeters maybe in the morning, and then at another time 0.25, and then 0.25, and then 0.25 to make the 1 millimeters. Why do we do that? Why don't we just go full out and distract this at 3 millimeters per day? Let me give you an answer. I would give you 2 reasons. One, because we know that as you do this, it's not just about the healing of the bone, but surrounding the bone, there are other forces as well, or other structures such as fibrous tissue, soft tissue, and therein are also vessels, and most importantly, nerves. And we know that a nerve grows by 1 millimeter per day. So we are accommodating that, because we're not just distracting a bone, but we're distracting the bone and the surrounding soft tissue, which will grow by 1 millimeter per day. Now, this distraction may sound funny because we know that there's something called Wolff's law, WOLFFS, and Wolff's law basically states that bone will adapt to the load under which it is placed. In other words, if I increase load, if I increase the loading, what will happen? The bone will remodel. In other words, it will become stronger to resist the load. And we see this example, in weightlifters or in the patients that play tennis, people that play tennis. The dominant hand will increase because it has greater loading, and you will find that there would be an increase in bone mineralization therein. And the counter, of course, would then happen with what you don't use, you lose. You decrease the load, you then decrease the bone density, and you'd have osteopenia. That then happens. And we see that even with stress, with prosthesis, where we'd have almost like a stress shield that then happen. So what is this thing that causes bone to heal? Or rather to remodel? It's a concept known as mechanotransduction. And what is mechanotransduction? It's rather that force that you use, or that external mechanical force ignites, or rather it signals, or it's converted to biochemical signals. So the mechanical signal gets converted in the body system to biochemical or cellular signals, which then cause the bone to start to grow in a specific manner. Remember, we said inflammation is driven by decreased oxygen tension, decreased pH, osteonegativity. So this mechanotransduction, this external force, gets interpreted or converted to biochemical signals, which will promote osteoblasts or osteoprogenitor cells to turn into osteocytes, or osteoblasts, which will turn to osteocytes, and that will then cause increased bone healing. So any force that you put, as Wolff says, if you increase the load, you will then increase the density thereof due to mechanotransduction. And that is what distraction does. It uses the concept of mechanotransduction in order to get this to happen. But remember, I said to you that what happens on the bone, we've got to accommodate the soft tissue. And that's how Davis then came in to then bring in something known as the Davis law, DAVIS, Davis law, which I think Oliver Wendell Holmes, it's interesting if you can read what he says about a mind that is stretched. He says a mind stretched, by a new experience can never return to its original dimension. So actually, Davis speaks to the soft tissue, and he brought in the stretch hypothesis rule. And he says also, as you stretch, the soft tissue also stretches, and actually the nerves stretch at 1 millimeters per day, as we know, as per the classification by Sutherland as well. So that's why we go at 1 millimeter per day. But now, let me go a bit deeper. There's also another reason, something known as tensile strength. What is tensile strength? It's basically the amount of elongation at a fraction of the original length. What does that mean? It means that if let's say we do an osteotomy, all right, to perform an osteotomy, that's day one. So the original length was what is from 0 to 1 millimeters. That then the osteogenesis happens. The tensile strain will now be 100%. Remember, it was 0. We went from 0, which is the original gap, to 1 millimeters. So it's 100% tensile strain. But day 2, we go to 1 millimeter again. So the gap is 1 millimeter, and then we extend by 1 millimeter. So what is the eventual tensile? It's strain. It's 50%, of course. And day 3 you can calculate is then 33%. So round about day 10, that's when we actually have wound healing, because around day 10 we have 10%, but around week 4 is where we have less than 1%. Now, bone can only heal when tensile strain is between 1 to 2%. Therefore, the osteogenesis will actually only start to occur around week 4, when the tensile strain is now less than 1%. Because remember, that's when we said our bone formation will happen. So you must know that the bone formation will generally only happen, it's not going to happen on day 1, but our bone formation will start to happen around week 4 because of the tensile strain. I hope you understand that. If you don't, just go back to your books and read about tensile strain. It's important to understand this concept. So we've now gone from latency, and then we know as granulation happens, because in latency we have hematoma forming, inflammation happening, and proliferation around day 5. But we disturb that proliferative period with random orientation that's occurring by now activating. And so we now have, this distraction osteogenesis happening. So that is exactly what it is. And so what you can then say is the difference between normal healing and distraction is that normal healing is unaided. It's going to happen. You have that hematoma and the proliferation will happen in an unrandom orientation. However, with distraction, it's guided healing, it's directional, it's aided healing. And this, the critical factor, as I've mentioned, and the stimulus is actually the mechanical strain that then happens, because that is that which stimulates proliferation in an orderly form. Why? It increases cell division, it increases the orientation so that we align with, the lines are parallel to the lines of tension. This is known as anisotrophy. And what causes that? I've explained. It's mechanotransduction. The mechanical force that is converted to a biochemical or a cellular signal. And this is what mediates this process. And we get guided proliferation. So we will then proliferate up until we reach a final stage. And what is our final stage is now that which we spoke about, which is consolidation. And what is consolidation? After we've gotten distraction up until the length that we want, we allow remodeling to take place. So consolidation will be remodeling. And as we've explained, the process of remodeling, even from normal wound healing, it takes a long period, which is estimated about 2 times the length or the duration of activation. And that is distraction osteogenesis, simply put. I hope you've understood it. Where do we use this? We can use it in the mandible, as explained, by Wolfgang, where it can be used as an alternative to orthodontic surgery, in our clefts, secondary bone graft. And the advantages is that as you get this increase in bone, there's also, with Davis law, remember, an increase in soft tissue. So you not only address the bone, but the soft tissue. So you can use this internally, and there are guidelines for internally. Of course, if you want, moderate gain that generally requires less than 2 millimeters, you would use that. But just to know the benefits of external and internal, generally external, you only have one direction of growth, and then whereas, with internal or external, rather, you can have multi directional growth. You can change to different planes and have the 3 different planes, example, and you have a greater expansion length than the limitation of less than 2 millimeters with the internal one. However, the disadvantages, you're going to have facial scars. You're going to have, a decreased distance because you've got longer arms that are required for equal force. And the pin care is one thing that is, going to be a problem, and hence you have a higher infection rate. But we definitely use it to distract the mandible. Examples of conditions we know in Pierre-Robin syndrome, you can also use it. But there is controversy because some people may not use it in Pierre-Robin syndrome and saying, look, no, we don't need it because we know due to the catch-up growth theory that in the first year of life, the mandible will grow and actually catch up. And others say, no, you're going to, cause injury to the dental follicles, and so it's not advisable. And others would say, no, man, conservative management are successful in themselves, so really we don't need this. But just to know that in Pierre-Robin syndrome, you can use it as as an option that is put there. But other conditions, hemifacial microsomias, we know with mandibular hypoplasia, as we would define it with our Prozitsky classification from grade 1 to grade 4, but grade 3, but with grade 1, what we must know with distraction osteogenesis, we know that we can only use it in grade 1 and grade 2. It will not work in grade 3 and grade 4. Just if you can revise Prozitsky, we know grade 1, it just affects the ramus, hypoplasia there, and then grade 2, it affects the ramus a bit with the body. However, what we know is that there's still continuation with the temporal, the TMJ, temporomandibular joint is still connected. Whereas in the others, grade 3 TMJ is not. Grade 4 complete hypoplasia, you can see you would just have a small body that is there. And so that it will not work because there's not enough bone stock in grade 3 and 4 to then use or apply this distraction technique. Other areas you can use is the maxilla. Of course, we know the 4-1, and the main advantages the main advances, you can actually advance 3 to 4 millimeters, but the disadvantage we've spoken about, the need for an increase in tensile force, so you can get some skin necrosis, the risk of osteotomy and bleeding. You may even cause blindness, and it may take much longer, but that's something we can use. Frontal facial advancement, calvarian bones are other areas where we can use, and of course long bones. So just to know areas where you can use it, but also quite important for you to know the adverse events that may occur, the side effects or the complications. One, it's increased complication rates, and we know that reported from anything between 0 to 35%. Others will give you 6 to 60%, so it depends which literature you read. But of course, there can be an increase in the complication rate. And what are those? There can be a problem with the device, a device failure. You can have pin pull outs. You can have infection. You can have damage to vital structures and adjacent joints. You can have inappropriate consolidation that happens, where you would have maybe premature union or non-union. But that's the whole point of distraction, is to try to balance between premature union and non-union, and that's why we distract. Osteotomy, you can have problems there, but also it's a long treatment as compared to other means that are there, and it's painful, and perhaps the learning curve is a bit higher as compared to other areas that we can use. So I think if we can get that, right, and we can understand it better, we certainly can use it for a lot of other areas. But our indications generally as plastic surgeons, we know when we've got bone length, like a small gap, less than 2, 3. Others may push to say no, you can use just bone grafts there, to then apply in that area, whichever technique you then use. Or if you've got a bone gap, up until 6 centimeters, others may push to 10 centimeters. They may say, no, here we can use distraction osteogenesis techniques, as per the Elizarov protocol. There is the Mescalet technique, wherein, you can then leave you put in a spacer, and then it forms a capsule around. You go in, you remove the spacer, but you don't cut out that capsule. That capsule, because it's vascular, it forms your membrane wherein you can now put in bone grafts, is another technique that, was now adapted. We know it as the Mescalet technique. But generally, you can either do a bone graft, you can either do distraction techniques thereafter you've got a gap, which we go into it when we speak about bone, or we just do a free flap, a vascularized bone that we bring in if we've got a greater gap. So it's a choice, or indications that you may use. So succinctly, I think that covers distraction osteogenesis. It's aided bone growth by applying a mechanical force. And when you apply this mechanical force, you then have periods. You do an osteotomy, you apply this external fixator, and then you will have bone healing happening, your hematoma, your inflammation. And as soon as proliferation then starts, around day 5, day 7, we then activate at a point of 1 millimeter per day. We've explained why we do so. And then after we've reached our predetermined length that we need, then we stop distracting. We don't remove the distractor, we leave it there to allow consolidation phase to happen, which succinctly is the remodeling phase that then happens. And once that has happened, given its time, which is generally 2 times the amount or the duration of activation, we then have this a strong bone that we can remove our device therein. And that succinctly covers distraction osteogenesis. I thank you for your attention. Looking forward to the next session. Take care. Bye-bye.